Good afternoon. Thank you for joining us for the next Ask the Experts COVID-19 virtual town hall. This is our fourth town hall since we had our first one on March 26. These have become really popular, and today we're going to have another great group of experts to talk about the various topics about this really large issue around COVID-19, the coronavirus. My name is Tom Piechota. I'm the Vice President for Research here at Chapman University, and I'll be moderating the town hall today. You'll be getting the current status on a lot of the issues and looking forward also as we talk about important issues in terms of restarting both the economy, how we restart certain things in our daily lives. And I think you're going to be really impressed with our great group of experts. I think here at Chapman, we're looking at a lot of these issues too. President Strupis sent out a real cautious, optimistic message today about looking forward to the fall semester, a fall semester where we would be meeting with our students in person, also doing that in a way where it's driven by the health conditions. We see some of the health conditions in terms of the cases. Our curve is probably flattening. I think we can all probably say that, but we can all probably say that we have when we look at our daily lives, we're all anxious in terms of wanting to get out of the house and wanting our economy to restart also. And I think you'll hear one of our experts talk about that today. But we also want to realize what this has looked like in the past. And I think you'll hear a great historian talk about that in terms of past events. So as I said, since we had our first town hall on March 26th, it's been incredible to just look at the numbers. When we had our first town hall on March 26th, we had 3,000 cases in California. As of today, on April 27th, 1 month later, we have 44,000 cases. So that's a growth in 11 times the number of cases. But you know, it's getting better. At Chapman, again, we continue to lean into the situation. I'm always inspired by specific cases and stories. I read it in the Orange County Register, and Chapman is highlighting a case of one of our physics professors, Stephanie Bailey, who brought this to her students and encouraged her students to write stories to homebound seniors. And really, those are unexpected gifts for those seniors in terms of getting letters. And of course, students got extra credits for it, but letters from physics students, and those are really great gifts for those homebound seniors who need things like that. In addition, you're going to be hearing from two experts today who got rapid response research awards supported by our K Family Foundation to support some really interesting work that addresses the issue on the coronavirus. So just a couple of logistic things before we get started. You'll have plenty of opportunity to ask questions of the experts. On the right-hand side, there's a question and answer place where you can post those questions. We'll get to as many as we can. So please, you can start posting those right now if you want. So without further ado, I'm going to jump right in and get started. I'm really pleased with our first speaker today. He doesn't really need a big introduction, but I want to give him a proper introduction anyways. He's President Emeritus and Professor of Economics, Jim Doti. He's the founder of the Gary Anderson Center for Economics and Research as part of the Arduous School of Business and Economics. Many of you, in addition to knowing him as a past president at Chapman, he has done the economic forecast for our community for over 42 years now. And what President Emeritus Doti is going to be talking about today is really comments on restarting the California economy, which is just so critical. So with that, I'm going to turn it over to Dr. Doti.
Thanks, Tom, and thanks for all you and your team are doing to make this kind of outreach to our community possible. As you can see, I'm here at Newport Beach. Just Bezad Binish and I just came out from our surfing experience. You can see my longboard in the back. Amazing what you could do with backgrounds here on this outreach that we have. Before I get into any information sharing, I just want to, since I have this opportunity, to express my gratitude and let everyone know how proud I am of all that we're doing. I think we all deserve pats on our back in the last month to do what we've done in terms of reaching out to our students and providing the kind of education we do in a different way, but nonetheless in a real quality way. I think it's to be commended, and it starts from the very top. I have a parent who, I know a parent who has a child or a daughter at Chapman, but 2 kids at other schools. And he mentioned to me that of all the schools, Chapman is providing the best communication flow as to what's going on during this pandemic. So from the executive team all the way to the faculty, administrators, and staff, all are a part of making this kind of educational outreach possible, deserve kudos, and I'm proud to be a part of that. Now, in terms of where we are, you mentioned that we're flattening the curve, Tom. We look at it, and since I'm a statistician, I look at the normal curve, and the normal curve is what you're talking about, flattening. But on the plus side, it's pretty clear we're on the downward side of that normal curve. That is, if you look at different nations, different states, look at California, whether it be death rates, infection rates, or even those who are spreading the disease. Everything is down on the downward slide, which is very good. Some states, as we know, are opening up as we speak. Other nations, I understand Spain now is open to their K through 12 schools. So the trend is positive. And in California, it's still a question mark as to when we will open. And it depends on what happens in these other states, these other countries. It'll be good that we can use them as a test case. I know that China now there's been no bounce back in China, even though they've opened up their economy. But we're going to be looking very closely at that. I'm sure the governor will. But I expect that by mid-June, we'll be in the first phase of an opening. And that first phase would mean salons, my goodness, I need a haircut, retailers, places of worship, and even offices, meaning Chapman University as well. Not contact, and it's going to be a different kind of opening. There'll be social distancing, probably some form of testing, and maybe even greater restrictions on those who are over 65. There's no question that that's where COVID-19 has had the most significant impact. Incredible. In fact, the death rate is 65 times greater for those 65 and over. So that means, Daniele, that I'll be able to stay here in Newport Beach when everybody is here back at Chapman University, since I make that criterion. What about the economy? Well, the statistics are going to be nasty for this second quarter, which is April through June. I mean, really horrible statistics that we haven't seen since the Great Depression. Probably 20% unemployment, probably a drop in real GDP of 15%. But the question is, what's going to really happen in the third quarter when states begin opening up their economies again, and the shutdown at least partially ends, and maybe we'll be in a stage 2 of opening the economy. Our current work, and I work on this with Ramon Sfera and Fidel Lawandi, we're preparing for our forecast. We see maybe a 15% drop in GDP the second quarter, but by the third quarter, which would be the June, July, and August quarter, probably an increase of 5%. Now, I have to point out that's quarter to quarter, so you're comparing this third quarter from a horrible second quarter. On a year-to-year basis, we're probably still down, but there will be certainly a recovery. Some businesses hurt more than others, and maybe we'll get into that in the Q&A. Small businesses have been devastated, and many small businesses will not return. And we can discuss that in more detail. If I could make a plug, I'll have we'll have more detail on the forecast, what's going on with housing prices in the future, mortgage rates, what's going to be happening in the small business side of the ledger, which is so important in the overall economy. We're going to have our economic forecast again. It will be different than what we've done before. It'll be a webinar, online webinar, and it's going to be on June 23rd and at 3 o'clock, and it'll be complimentary. So we hope people will sign up and see it. If I can borrow a Churchillian phrase, this isn't the beginning of the end, but I think we're at the end of the beginning.
All right. Well, thank you very much, Dr. Doti, and what a great way to end the presentation. And I'll give it another plug for the economic forecast. It is really always a great event. It's too bad that it's not going to be in person this year, but if you can do it virtually, it will be a really nice event. Always really good information too, because really he and his team are really credible sources for providing that forecast. So with that, I'm going to move on to our next expert. Our next expert is Dean Jennifer Keene. Jennifer is a professor of history and dean of the Wilkinson College of Arts, Humanities, and Social Sciences. She's an expert and well-published in the World War I era. Today, she's going to be speaking on a really interesting topic on the Spanish Influenza Pandemic of 1918, which I think we can learn a lot from, and how we can learn from that in our current COVID-19 crisis. So with that, I will turn it over to Dean Jennifer Keene.
Great, thanks, Tom. Thanks for the invitation. I'm really pleased to have a chance to be included in one of these research town halls. I've attended all of them, and I've learned a lot. And so I also appreciate the opportunity to share a little historical context for understanding our present situation. So you've probably been hearing a lot in the news about some comparisons to the Spanish influenza epidemic of 1918, which still is the worst pandemic in modern history. And so I wanted to start by just maybe sharing a bit of a big picture view of the pandemic, and then talk about some insights that we might be able to glean from the past for the present. So you can see, I don't have to read all of the figures that I've put up here for you, but I think what you can kind of immediately recognize is what I mean when I say it's still the worst pandemic in modern history. You can see the 50 million is a low estimate of the global numbers of fatalities. And you can see in terms of the numbers of deaths in the United States, 675,000. Well, nobody's projecting that, even the worst case scenarios for the United States. And it's interesting also to look at 12 years as the reduced life expectancy for adults in the US for 1917 as a result of the huge impact that the influenza epidemic had. It is worth mentioning that the influenza epidemic of 1918 coincides with the First World War. So at a moment that you also have the most destructive war in modern memory, you have this horrific pandemic at the exact same time. Another thing that we hear a lot about in the news are waves, because of the predictions that if we lift social distancing measures too quickly, we could experience a second wave. And here, if we look back at the 1918 pandemic, we can see that to a certain extent did happen. There were 3 waves of infections, and the first wave, most historians believe, would not even really mention any sort of footnote in a history book, because although there was a high rate of infection, it was relatively few deaths. It didn't look any different than kind of a normal flu. But it was the second wave, which we saw the really dramatic spike in fatalities, and the sense that the virus had mutated and become even more lethal. And again, just always remembering the context of the war. If you know your World War I history, you know that November 11th, 1918 is the armistice. This is when fighting stops along the Western Front. And so if you look at those final months of fighting along the Western Front, when there's a massive Allied push, again, a spike in fatalities, most of the American fatalities in the war occur from September to November of 1918. You can see again that coincides with the spike in deaths on the home front from the Spanish influenza epidemic. And so you're just at this moment where a death is everywhere, and it's not just the soldiers who are fighting who are also dying of the flu, but people on the home front as well. And then there's this third wave that occurs in early of 1919, and this is in some ways, if you study this period of history, almost the most tragic wave, because you have in November and December this rejoicing of people around the globe that they lived through the war, and then of course many did not live much longer. Succumbed to the flu, and some of the really heartbreaking letters I've read in my research from families have come from families who are waiting for their soldier to return home from France, only to get a letter that he's perished in this third wave of the Spanish influenza epidemic. So a lot of tragedy and a lot of fatality. I often get asked, why was it called the Spanish flu? It did not originate in Spain. There is some debate over where it originated, and Spain is not one of the contenders. But because of the war, there was press censorship in effect throughout the United States, throughout Europe. Spain was a neutral nation, so it did not exercise press censorship. So when the influenza epidemic began to worsen, it was first reported heavily in the Spanish news. And so that's where the idea that it had originated in Spain came from. And this cartoon, which is from the Los Angeles Times, I wanted to kind of show it to, again, kind of put it in a kind of different context, not just the big number context, not even the context of the war, but the American political context. In a way, sort of similar to our own era, this was a period where there was a lot of anti-immigration sentiment. America had just experienced huge waves of immigrants from Europe. And so you can see also that the idea that the Spanish were the first to report the flu did not really tell the whole story in terms of what people meant when they called it the Spanish influenza epidemic. So you kind of think like Chinese virus maybe is popping into your head at this moment. If you take a look at this cartoon, this is when social distancing measures were being introduced into Los Angeles in 1918. And you can see at the bottom both the glee of the school children, yay, school's closed, and the anger of the theater owner, oh no, I'm going to lose my income. But you can also see the racial caricature of the virus itself, which is sort of this swarthy foreign villain. And that, I think we need some context in terms of the anti-immigration sentiment and racial stereotyping, ethnic stereotyping of the era to make sense of. Now, when we think about the politics and the social context of the moment, it may be obvious, but I want to state it anyway, they did not shut the war down. So while they may have shut down schools and they may have shut down theaters and churches and businesses, the war continued. And so that created a lot of opportunities for the virus to spread. I mean, look at this picture now, which is of a troop ship arriving in France, and you just look at it now thinking of our COVID moment as just this infection petri dish. And that's, in fact, what many of these troop ships turned into. And so hospitals, especially in France, quickly became overloaded. And even on the home front, Philadelphia in 1918 made a really fateful decision to go ahead with a Liberty Loan parade in early September, even though flu had already been detected in the city. And that turned out to be a huge mistake, because when we then look at what happened in Philadelphia right thereafter, you can see that they experienced a huge spike in terms of deaths from the pandemic, and Philadelphia actually was the place in the US where the pandemic took the heaviest toll. So these kinds of charts have also become really popular right now because it seemed to indicate the importance of social distancing in terms of instituting those measures early, not lifting them too quickly, and this can become perhaps a way to flatten the curve. I wanted to just sort of point out another similarity between their time and ours, which is that there was no federal direction or coordinated effort in terms of how to handle the influenza epidemic. Woodrow Wilson, who was president at the time, never spoke about it, even though he himself suffered from the flu. And really, cities, mostly mayors, were left to their own devices in terms of figuring out what to close, when to open, and how to handle the pandemic. And it's interesting, even over a 100-year period, with the growth of the power of the federal government, we're in a somewhat similar situation. We do, however, live in the shadow of the 1918 Spanish influenza epidemic. They did not know viruses existed at the time, but interest in understanding what had happened spurred medical research. So then viruses ended up being discovered in the 1930s, and a whole host of medical advancements that we benefited from, in fact, were initiated in response to the flu. My very, very last point is going to be very careful, or skeptical as I am, of all these articles you're reading in the newspaper that claim nothing will ever be the same. The Spanish influenza epidemic is pretty much completely forgotten. It was worse. Its impact was more dramatic, but yet within a few years, people had almost completely forgotten that it ever happened. And so people do have a desire to get back to normal. We call the 1920s the return to normalcy for a reason. So I'm not 100% sure nothing will ever be the same. Thank you.
Great. Thank you, Jennifer, and really interesting and amazing to see how after 100 years, some things, the similarities and then some differences between what happened in 1918 and what's happening 100 years later also. So lots of questions that come out of that. I want to move to Jason Douglas. Dr. Douglas, an assistant professor of public health in the Department of Health Sciences in the Keene College of Health and Behavioral Science. He worked disadvantaged communities, investigate social and environmental determinants of health disparities. I'm really excited that he's one of our recipients of our COVID-19 Rapid Response Awards that we just gave out 2 weeks ago. And he'll be talking some today about that in terms of looking at the extent of some of the analysis that they're doing in the communities in New York and Los Angeles. So with that, I'll turn it over to Dr. Douglas.
Great, thanks a lot, and thanks to everybody for having me here today. So yes, it's a great honor to receive some K Family Foundation funding through Chapman to pursue this work that I'm going to be talking about today. I'm going to be describing an examination that I'm conducting with faculty and student colleagues at Chapman, looking at social and environmental determinants of COVID-19 incidence and mortality in New York and Los Angeles. And I'd just like to quickly draw attention to my faculty colleagues, Lawrence Brown, Angel Miles Nash, Emmanuel John, Georgiana Bostein, as well as some of the amazing students that we're working with, Olivia Lounsbury, JC Sarah, Elmer Camargo, Emma Hughes, Carla Vasquez, Emma Roth-Lutner, and Jeremy Tang. Okay, so today I'm going to talk about the overall study that we're pursuing, as well as present some very preliminary data. So in this project, just quickly, what we're seeking to do is identify social and environmental factors that may manifest in COVID-19 health disparities, that is, uneven rates of COVID-19 amongst disadvantaged communities. And what we hope to do with this data is develop a viral pandemic risk index based on study results to help inform future policies and practices. So to set the tone for this study, I think it's important to at least briefly review what we already know. And I thank Dr. Keene for setting the context for this because, building on Dr. Keene's talk, what we do know is that ethnocultural minority populations throughout history have experienced higher rates of pandemic-related morbidity and mortality. For example, in the context of the 1918 influenza pandemic, in the US context, African Americans experienced a 35% higher mortality rate than white Americans did. Now, this is particularly concerning because, we've seen this pattern throughout history. Through the 1950s, all the way to the H1N1 outbreak in 2009. And this is particularly concerning for several reasons. Number one, hot off the press last week out of the Journal of the American Medical Association, it's been confirmed that people with underlying conditions such as obesity and diabetes are at increased risk for severe COVID-19 symptoms. Now, this may lead to additional disparities for our ethnocultural minority communities, because we already know, for example, we see higher rates of obesity, diabetes, hypertension, and I'll just draw your attention to this graph quickly, looking at the age-adjusted prevalence of obesity among adults over the age of 20 in the US, where we're seeing, for example, and I'll just for the sake of time review the total numbers, but what we're seeing is, comparing white communities, non-Hispanic white communities rather, with non-Hispanic Black, non-Hispanic Asian, and Hispanic, we're seeing the highest rates of obesity amongst our non-Hispanic Black and Hispanic populations. So in the interest of time, I'm just going to review the total numbers and move on to the study at hand. So our research strategy, what we're doing is taking a comparative approach to look at COVID-19 morbidity and mortality among minority and non-minority groups in the cities of New York and Los Angeles. Now, it's no secret that we're already seeing health disparities related to COVID-19. For example, in the New York context, we're already seeing Black and African Americans experiencing higher rates of COVID-19, both in non-hospitalized, hospitalized settings, as well as mortality rates than any other ethnicity or race, only followed by Hispanic and Latino. So in this context, it's important to develop an understanding of why we're seeing these differences. So in the current research, what we're seeking to do is develop an understanding of COVID-19 incidence and mortality associations with a number of pertinent social determinants of health, including race and ethnicity, which you already know, median household income, for example, access to health insurance exchanges, hospital resources, as well as comorbidities. So hot off the press, in some of my preliminary analyses, looking at access to hospital resources in New York City only, it's interesting that we're seeing, if we look at the trend in hospital resource data as evidenced by number of hospital beds, for example, which we know is predictive of morbidity and mortality within our communities. If we take baseline numbers from last year, November of last year, for example, and compare them with bed number changes by borough in New York City, including Bronx, Brooklyn, Manhattan, Queens, and Staten Island, as you'll note this green line here, we already saw the highest bed capacity in Manhattan compared to the outer boroughs, but we're also seeing the highest bed increases in Manhattan. Now, it should be noted that most of the more diverse communities live in the boroughs at this point, Bronx, Brooklyn, Queens, and Staten Island, for example. So again, this data is hot off the press, so please do excuse the SPSS outputs. But when I ran simple pairwise analyses, looking at, since we're seeing high rates of COVID-19 in Black and Hispanic communities, what I did is I compared the number of beds available per 1,000 people of the population at the zip code unit of analysis. So comparing zip codes that have a higher percentage of Black and Hispanic communities, what we see is per 1,000 people of the population, there's an average of 11 beds compared to 63 in all other communities. When we look at intensive care unit beds per 1,000 people of the population, what we see is only half a bed per 1,000 people of the population in Black and Hispanic communities, compared to 3.6 in all other communities. Now, we already know there are test differences, but look, in terms of who's being tested in total, look, credit to Cuomo, put the good stuff forward and ensured that people are being tested equitably. So what we're seeing is that the average rate of testing per 1,000 people in the population is very similar between Black and Hispanic communities compared to all other communities. And then obviously we know that Black and Hispanic communities are testing at a higher rate. Testing positive at a higher rate, that is. So just one last bit of statistics that I'll share. When controlling for population density, race and ethnicity, Black and Hispanic proportion of the community, what I found was that we are seeing higher incidence of percent positive tests, that is higher rate of cases associated with concentrated disadvantage. For example, as the number of percent insured people, as the percent uninsured folks in a community goes up, right? We're seeing increases in COVID-19. But as income goes up, COVID-19 goes down. And then finally, we see an inverse relationship with hospital bed availability. As beds go down, COVID-19 goes up, which indicates that communities that are hardest hit may not have the hospital resources necessary to treat effectively. So implications for public health, what we seek to do is use this data to develop a viral pandemic risk index that may be scaled up and tested to assess risk across US cities, and hopefully to inform disaster preparedness policies that allocate equal protections for all people in all communities. So with that, I'll say thank you very much, and please do stay safe and healthy.
Mike, Tom?
Thank you, Dr. Douglas. And we already have a lot of great questions coming in. And before we get to those, I want to end with two faculty members that are doing a lot of great work with our students here at Chapman, both in the Schmid College of Science and Technology and the Fowler School of Engineering. The first person that's going to speak is Dr. Eric Lindstedt. He's an associate professor and associate dean of academic programs in the Fowler School of Engineering. He's going to be talking some about some really exciting work and great outreach that is going on with work that they're doing on 3D printing of face shields and getting those face shields out to people that need them in our community. So with that, I'm going to turn it over to Dr. Lindstedt to talk about that work.
Thanks so much, Tom. Really appreciate it. Really appreciate being included. So like Tom said, today I'm going to be talking a little bit about how in the Fowler School of Engineering and the Schmid College of Science and Technology, we've been kind of taking action and using some of our engineering and science skills to do something that hopefully helps out our medical professionals that are working under these tough times. I should start by saying that really, even though I'm the person who happened to be volunteered to give the pitch, this is more or less a celebration of all the wonderful students in the Schmid College of Science and the Fowler School of Engineering. And let me also give a shout out to John Humphreys, who's an instructor in Fowler, who really has been absolutely instrumental about lighting a fire under the rest of us and really making us realize that we can do some amazing things if we all work together, even though certainly our typical model for interacting with our students has changed drastically. I think at this point, pretty much everyone's aware that over the last couple of years, we've been working diligently to build a new School of Engineering at Chapman. And when you build a new academic unit, one of the first things that you have to ask yourself is, how do you differentiate from all the others out there? And relatively early on, the few of us that were thinking about this, Andrew Lyon and myself and Greg Goldsmith, we really thought that if you're going to build a School of Engineering, then you need to make sure that it's human-centered, right? You have to believe that engineers are, by definition, builders. And when they're thinking about building, if they're not keeping people at the center of the design process and kind of the center of their focus, then they're not doing right by their professional training. So one of the things that we spend a lot of time thinking about in our curriculum is, how do we engage students so that at a moment's notice they can really engage and solve hard problems? And this is something that starts early in our Grand Challenges initiative from day one, the idea that some problems are just so tough you might not be able to find a solution, but still there's a lot to learn in the process. Well, part of that and part of that human-centered thinking is thinking a lot about design, how when you build something, when you fabricate something, it can't just be cool, it actually has to serve a purpose for the people who use it. And really, as difficult as the last couple of months have been leading up to where we are now, this has proven to be an opportunity for our students to really show that they are able to think critically about tough problems and solve them. So no surprise to anyone, it's been all over the news. There's been a huge shortage of protective gear for all the frontline workers that are helping to treat patients with COVID in a variety of environments. And in some cases, medical professionals are going in to do their jobs without any protection whatsoever, which puts them at grave risk. And so we started to think, how is it that we at Chapman can maybe do something to help them out? And a natural thing that kind of came to our minds was the fact that we have a very unique curriculum in Schmid and in the Fowler School of Engineering that focuses on 3D printing and manufacturing. In fact, we have a 3D printing and modeling course where instead of a textbook, the students basically get their own 3D printer that they're able to take home and use at home. And so while a lot of universities were able to quickly start helping out by producing some PPE, I think Chapman is quite possibly the only university that's been able to do this with a distributed model that engages students from off campus. And so we took our students who all are working at home now and with their 3D printers, and we took our faculty that have access to 3D printers, in part thanks to the wonderful learning infrastructure we have at Chapman, and just because we're all hobbyist nerds who have stuff in our own garages. And we started going to work. And it didn't take long for some companies to put out some totally open source designs that you can 3D print in order to manufacture face shields. And so that's what we did. I should say that one of the things that really helped us transition to this remote fabrication environment so easily is the fact that we already use a lot of industry tools in a lot of our courses. So in particular, we use Slack as our communications platform. If you aren't familiar with Slack, it's kind of like Microsoft Teams, only perhaps a little bit more robust and a little bit more geared toward technical projects. And so we were able to take our students that were already on Slack and be able to parcel out 3D printing assignments. They in turn were able to use the equipment they had at home to print these face shield holders. And basically the way this works is you print these using a PETG plastic filament. It's the same thing that perhaps your plastic water bottles are made out of. So it's a very strong plastic. And then you 3-hole punch a 3D transparency that we were all used to dealing with before everything went digital, and you just attach it to the front, and it basically gives you a full face covering. This design has been vetted by the National Institutes of Health. Our students are actually following some pretty strict quality control measures. We make sure that everything are sterile. A lot of our students are washing these things down with lab alcohol before they ship. And so they've really done an absolutely phenomenal job of rising to the occasion and showing that just because we aren't on campus and they're not receiving sort of their typical instruction as engineering students, they still understand that the role of the engineer is to build, and they have been able to build even though it isn't in sort of our 2-day a week typical delivery pattern. So to date, we have printed more than 4,000 face shields between the students and the faculty. In addition to these face shields, we've also been contacted by various groups. Some of our students have printed parts for the Mayo Clinic for ventilators and things of that nature. And, you know, again, this is done relatively easily because of the educational model that we've built into a lot of our core curriculum in the Fowler School of Engineering and the Schmid College of Science and Technology. And you know, if you look at the unit cost for these things at 75 cents, we're well positioned to really scale this up and hopefully make a difference in some lives of the folks that are out there really working hard for us right now. So that's my spiel. With that, I'll turn it back to Tom.
All right, great. Thank you, Dr. Lindstedt. And really exciting stuff that our students and faculty are working on. With that, I want to introduce Dr. Greg Goldsmith. He's an assistant professor of biology and director of Grand Challenges in this initiative, which is really one of our exciting initiatives here at Chapman that you'll hear about. He's going to be talking about that and also some exciting things that our undergrads are working on collecting data. And again, this is another one of our COVID-19 Rapid Response Awards. And he's going to give you a sneak preview and some of the early results that they have. So with that, I'm going to turn it over to Dr. Goldsmith for his short presentation.
Thanks, Dr. Piechota. It's a pleasure to be here today, and thank you all for taking the time to come out and listen. I understand that you have no shortage of COVID-19 media coming in your direction in general, so I appreciate your taking the time, and it's an excuse for me to shower and shave and put on a clean shirt. This is work that we've been doing for the last month or so. That's really the result of what happens when you have a bunch of highly motivated students that are interested in contributing to our understanding of COVID, and whose normal research in my lab has been disrupted. So there's a great list of students at the bottom, and in fact, several students brought along their friends for this project. And we're really interested in understanding the response of higher education institutions to the outbreak of COVID-19. And that's around thinking about both how and when institutions responded to the emergence. This is important because we know that closing schools slows the transmission of viruses and other infectious diseases. I'm showing you on the right work from a model developed in London. On the vertical axis, you see the number of hospital beds needed, and on the horizontal axis, you see the date. And when you look, those are the various curves that represent different scenarios for how many beds would be needed, ranging from do nothing to very strict social isolation. And the green line that you see there is what happens when you close schools and universities. So this is the so-called flattening the curve idea. And so we're trying to understand to what extent campus closures affected the rates of COVID-19 transmission, and how quickly different institutions responded to information and guidelines from public health officials, given that we know that there's such high variation in how different states and counties responded to this. And then finally, you might want to know whether the characteristics of the institutions, their size, whether they're public or private, affected those types of decisions. So I'm just going to give you today, in the interest of time, a quick look at some results. I want to make sure we have plenty of time for questions. Again, here's some dates on the vertical axis, and what I want you to see is that the first time the notice of COVID-19 posted on different college and university websites varied significantly. So there was some institutions that let their stakeholders know that this was going on towards the end of January, and others really didn't notify their students and faculty and staff until the end of March. Nevertheless, the World Health Organization declared a pandemic around the 11th of March, and very quickly, most institutions transitioned to online learning. It took about 6 days from the announcement to get to online learning on average, although you see some variation there because the outbreak coincided with a lot of spring break. So we can start to look at some of these patterns. This is data from 400 institutions, painstakingly pulled off of institutional websites by my student collaborators. And you might now, of course, be wondering, where did Chapman University fall in all of this? And the answer is that Chapman actually acted faster than most institutions. Each of the red arrows represents where Chapman fell, and you can see we were certainly ahead in terms of letting the university community know that COVID-19 was emerging. We announced online learning and transitioned in less than 24 hours, actually, and we're right around the median. So I think that speaks well to the institution. We're obviously in uncharted waters right now, and everyone's making it up as as fast as they can, but I'm hopeful that the data that students are collecting can help inform how we think about these issues moving forward, particularly in light of, for instance, Dr. Keene's comments on what it might mean to have a second wave. So I wanted to end just by saying something a little bit more synoptic in my role as the director of a program on campus called the Grand Challenges Initiative. Certainly, we're experiencing a number of grand challenges even before the emergence of COVID-19, and I think it's compelling to think about the role of higher education in that context. I think higher education plays a really critical role for the common good, and you know, this is more than a teachable moment. Our students in science and engineering, and as you saw from Dr. Douglas's presentation, they are ready and motivated to make the world around them a better place. And I think that we have an opportunity to establish higher education and institutions like Chapman as leaders in setting the tone and providing the information that we need to make great decisions. And I think that COVID represents a lot of the challenges that an institution like Chapman or other higher education institutions are poised to address, and that's that solving grand challenges like COVID-19 are going to, as you heard in the last 30 minutes, require combining science and engineering with topics like economics and history and sociology and the arts and otherwise. And so I'm excited about what the university and what universities writ large can offer as we move forward in the coming months. Again, thanks to everyone for tuning in. And with that, I'll hand it back to Dr. Piechota for comments and questions.
Great, thank you. And that is really inspiring to see what you have our students working on, and also great to see where Chapman lies in comparison to other institutions. And we really appreciate the good work that you're doing. We have had tremendous questions, and I really appreciate what the experts, they've already been responding to some of the questions, so I really appreciate that. But within the next 15 minutes, I'm going to try to get to as many of those as possible, because I think it's really great to hear from the experts. The first question I'm going to post is actually from a Chapman supporter, Tim K, and it's a really interesting question. The question is for Dr. Doti, actually. So the question is, Tom Barrick, who's a well-known developer in LA, predicts a terrible impact on commercial real estate. Dr. Doti, can you talk some about what you anticipate this looking for the impact on commercial real estate? And I might add to that, do you think the change in the way that companies have adjusted to working remotely, is that going to impact commercial real estate also?
Great question, Tim, out there. Tough question. It appears that rental and lease payments have been held up, and we don't know the extent of it, but anecdotally it's significant. And when you look at construction levels, the one area where permits are way down is commercial versus residential. Question is about the future. I really believe that that things are not going to change all that much on the commercial side in the long run. There may be a 6-month period where everyone's waiting and seeing, but you may recall 5 years ago there was a feeling that because of changes in the office configuration and online and remote kinds of delivery of services, that it would heavily and negatively affect commercial. That didn't happen. And I agree with Jennifer that I think that I'm more in her line of what happened after the Spanish flu, that I think after a year things will settle on the commercial side and there will not be a significant change in demand. That's not the case, however, with small business, restaurant owners, and so on. I think there will be real fallout there, long run fallout in those sectors of the economy.
Interesting. Good. Thank you. And the next question, I am going to go to Jennifer, and the question I think on that is, I think a specific, and you might have touched on it, but maybe talk more about it. How did the 19 to 18, how did it end in 1918? And then I think also look at that and maybe compare that to why is it different? You talked some about the similarities between 1918 and today. What are the differences and
Right.
why might it look different? You know?
Right. Well, I think that one of the, a lot of what happened with the flu, both why it was so lethal, one of the things I didn't have a chance to mention was that the flu was unusual, not just in its severity, but most influenza epidemics, and the COVID-19 epidemic has this too, has a more of a traditional U-shaped curve. I think Dr. Doti mentioned this, that, high mortality among the elderly, and traditionally influenza attacks the very young and the very old. And in 1918, the curve was actually a W, so it had an unusually strong impact on young adults from, say, age 15 to 35, which you don't see in a normal influenza pandemic. So there are a lot of questions, its origins, why you have that W curve, how does it end, that to a certain extent people are still speculating about. I mean, the basic argument is that the flu in the third wave, it mutates, it's less virulent, and it basically burns itself out as so many people have become infected that a kind of immunity builds up in the population, and it essentially disappears. Of course, it's only been studied recently in terms of them even being able to isolate the virus and to begin to sort of understand its effects a little bit more. In the question about differences between then and now, I do think, well, first of all, we're not fighting a world war, big difference. Second big difference is our general health of our population is better. When I showed you those the statistics on age, the average age lifespan being decreased by 12 years, well, it wasn't very high to begin with. I mean, the average adult male lived into their early 50s. So the general health of the population, pollution was worse. It was a coal burning society. There was a lot that made people particularly susceptible to a respiratory disease, and also epidemics were typical. Tuberculosis was still around. Measles epidemics were very common. So I think in that sense there's a big difference, and also the advances we have. We know it's a virus. We have ventilators. We do have a World Health Organization and a CDC. I know they're not like very popular organizations right now, but the idea that you would need to have some kind of coordinated national and some sort of coordinated global response in the result of a pandemic, these were public health initiatives that came out of the influenza pandemic. So we are maybe not, we weren't heeding the warnings all along, but if you look back, in 2018, when the CDC was commemorating the influenza pandemic, almost everything they're telling us today, they were telling us then. So we just haven't been really listening. And that's where I was ending before, saying everybody wants to look to history for lessons of the past and insights, but we don't study a lot of history in America. So everybody needs to take history. That's my plug for history.
That's right. That's why we have you on.
I want to plug for history.
Good plug for history. That's National History Day.
That's right.
My next question, I want to pose it to Dr. Douglas. I think the question is around availability of medical assistance and how that in relation to, I guess, a lot of socioeconomic factors, and whether you talked a lot, I think, about the socio-demographic factors, but I think it's also possibly around economic status too. And are some of those things you're looking at as part of your study, the idea around the availability of medical assistance in those different communities you're looking at?
Yeah, sure. And those are factors that we're going to have to additionally look at. Because I mean, look, even since the passage of ACA, for example, in the context of health insurance, we're still seeing uneven access to health insurance, whether it be to healthcare, rather, whether it be in terms of overall access to health insurance or quality of care, for example. So, while there's certainly sociodemographic factors that associate with increased incidence and prevalence, you know, there are additional social factors, environmental factors. You know, for example, concentrated disadvantage is socioeconomic, and we are seeing strong associations with incidence and prevalence in terms of median household income. So, you know, I think there's a litany of factors that, you know, we're really looking at in terms of what is the context of, you know, low-income communities of color in terms of, you know, increased incidence and prevalence amongst our communities. Is it a function of concentrated disadvantage? Is it a function of unequal access to resources, hospital resources, health promoting resources? And I think, you know, the part of the puzzle that we're trying to unpack here is how all of these factors interact. So it's a very good question, but that's something that we're investigating. Mm-hmm.
My next question is, I think I'm going to give it to both Eric and Greg. Both of your presentations, you're great examples of our students involved in different efforts that are really important in research and outreach. I guess maybe speak a little bit more. Our students and certainly our faculty were thrown into kind of this situation and quickly had to adjust in terms of teaching online and learning on remotely also. Maybe speak a little bit more in terms of how have the students responded to all this? You gave a little bit of glimpse in terms of them doing remote research, and Eric has demonstrated a little bit about different activities, but give a little bit of perspective in terms of how students responded to all this in terms of the change that they were thrown into in mid-March and now continuing the semester this way.
Sure. I mean, and, you know, just prefacing this with, I teach computer science, right? And so admittedly, I have it a little bit easier than the poor person that has to teach sculpting remotely. But I would say overall, our students have done an absolutely exceptional job transitioning to the new model. And that's not to say they don't have every right to be disappointed. I think that's true for the faculty as well. We want to be there with our students engaging. You know, in the School of Engineering, I think something that's been very beneficial to us is that we have always sort of tried to integrate industry standard tools into our curriculum. And of course, when you're talking about computer science and software engineering, this is a field where a lot of those tools really are all about remote work and geographically dispersed teams. So in that sense, through tools like Slack and code versioning systems and ticketing systems, we've had the infrastructure already ready to go to support this deployed environment. So that's been incredibly useful from my perspective. And, you know, I think the other thing is it was pretty apparent early on, at least in interacting with my students, even though we made a transition to online, they still cared very much about synchronous communication and interacting, right? And so I would say that just because we've transitioned online doesn't mean that now all of a sudden our classes are flipped and they behave like MOOCs, where as a faculty member I post some material, they get to it when they get to it, and then on a Sunday afternoon I make a margarita and then grade at my convenience, right? You know, we're very much still engaged with the students. It just so happens to be that the internet separates us, but overall I've been impressed, and I think especially from an engineering perspective, where we really pride ourselves on the fact that our students can go out and get jobs with the skills we teach them. You know, I can see why that is. Even as freshmen, we've shown them just the nuts and bolts, how to be a team player in an organization that can't necessarily, just because of physical constraints, be together, let alone if there's a pandemic happening.
Great, thank you. Dr. Goldsmith.
Yeah, I think that, of course, my priority and the priority of the faculty is that students take care of their health and the health of those around them. And we can't expect our students to meet all of our learning objectives if they're not first taking care of themselves. And these are challenging times in that regards. And so different students are facing different circumstances. Some of our students are logging on to class at 5 a.m. local time from Hawaii. Some of our students have parents that are undergoing significant changes in their work life, and you may be under the roof now with your 4 other siblings and the family dog, and that's a challenge. And I think the faculty has been cognizant of that. But nevertheless, where students are excited about engaging in research and public engagement, we're ready to meet them and work with them. And I've been very impressed with our students' ability to adapt and move on the fly to really almost unimaginable scenario 3 months ago.
Great. All right, I'm going to do rapid fire. Everyone gets a last word. And the question I want to ask, and I'll start with Dr. Doti. We've been probably over a month now where we've had stay-at-home orders. Everyone's getting anxious to get out of their house and get back to work. What should make people feel optimistic or concerned about where we're at right now, given all the critical issues you've just talked about? And the potential of either reopening things up in everyday life, everyday society, businesses, and so forth. Dr. Doti, what's your final words for everyone? You got about 30 seconds.
Okay, no, I think we all have a strong reason to be optimistic. I think it goes back to our economy, and we're already seeing the results of it. In just the last couple of months, we've transformed the way we do things, and it's the resiliency of people, the free enterprise system, and I believe that in the future we'll see even more of it, more of a bounce back in very innovative ways. And it goes back to the people that make this economy so great.
Great, thank you. Dr. Keene. Might be muted.
Sorry.
Oh, there you are.
I would say that I think that the idea of service and of service to our community has a long history in the United States, and it's where we really live in our communities and we turn to one another in times of hardship and crisis. And I think that while our newspapers are full of, the people who are ignoring the physical distancing regulations at Huntington Beach, on the other hand, we have so many great stories, like the stories of our students who have really stepped up, and that is the story of America. And it really does show that the country is built and it's maintained by the people who live in it. And we have reason to be proud of ourselves at this moment.
Great. Dr. Douglas.
I'll say the response from the scientific community. Honestly, I've never seen anything like this in my lifetime. So many folks across the globe have dropped their entire research programs to contribute to solving, various facets of this wicked pandemic. And just seeing the level of data sharing, folks are posting data all over GitHub. Getting that data up, preliminary analyses to really inform policy and practice, I think is so promising, and just seeing how dedicated people are to this. And I just want to say, huge shout out to my research assistants. You're doing awesome.
Dr. Lindstedt.
Yeah, I think for me, the one thing that keeps me optimistic is the fact that through all of this, I've watched my students and my colleagues just basically go out of their way to be kind to one another and show each other courtesy and things like that. So, I think that's what I really am going to take away from this. No matter how bad things are, it seems like it's bringing out the best in a lot of people, and that's pretty cool to see.
Great. And Dr. Goldsmith, you get the last word.
Excellent, thank you. Yeah, I think that as I tried to mention in my talk that we have the potential here for an incredible renaissance in knowledge in the coming years, and no one wants a renaissance in knowledge at a cost of any life whatsoever. These are terrible circumstances. Nevertheless, I hope that what comes of them is some really fantastic science and engineering and history and sociology and art that make the world a better place.
Great. Well, thank you all. I want to thank the experts for another great conversation. Thank you all, the people that participated, for great questions. And we apologize if we weren't able to get to all those, but we tried to answer a lot of those online and in person. These presentations will be posted on the Ask the Experts website, which has been posted online, and the contacts for our presenters, and the recording will also be posted. We will be having another one of these. We'll be having another one on May 7th, so please come back and share it with your friends. And with that, thank you, stay healthy and stay safe, and have a good day.